Good morning, everyone. Thank you so much for joining us today. My name is Terrence Henry, and I'm the Executive Director of TAMEST. That's the Academy of Medicine, Engineering, and Science of Texas. We're glad you could be with us today, and thank you all for joining us. We're bringing together a couple speakers today to look at the outbreak of COVID-19 in Texas and what the science can tell us about what's happening and what the next steps should be, as well as steps that individuals and officials can take to help mitigate the outbreak. I'll just spend a couple of moments talking briefly about our organization. We are the Academy of Medicine, Engineering, and Science of Texas. We're a statewide network that brings together some of the top scientists in Texas. Our membership includes more than 300 members of the National Academy of Medicine, National Academy of Engineering, National Academy of Sciences, as well as the Royal Society and the state's Nobel laureates in Texas. We are supported by our 18 academic member institutions, and we'd like to thank them for their work and for their support of TAMEST. Today, really, as I mentioned, we're bringing back a group that we heard from earlier this year, actually 2 months ago on May 14th. As restrictions in Texas were being lifted, we brought this group together to take a look at the state of the pandemic and what next steps should be. And today we've asked them to come back as we're facing a crisis point and looking at incredibly high numbers of infections and hospitalizations. And we've asked for them to prepare some presentations on what the science says about the spread of COVID-19 in Texas, and again, what steps we can consider to help mitigate the outbreak. We are going to have time for questions at the end of the conversation. If you'd like to submit a question, you can do so using the Q&A function, and we'll have a moderated Q&A towards the end of the presentation. We are still waiting on our moderator to join us. That is Peter Hotez. He's the Dean for the National School of Tropical Medicine at the Baylor College of Medicine. But in order to go ahead and move forward, we'll go ahead and get started with the presentations. We're very happy to have two of the leading voices on COVID-19 in Texas joining us today. Our first speaker will be Dr. Rebecca Fisher. She is the Assistant Professor of Epidemiology and Biostatistics at Texas A&M University. After we hear from Dr. Fisher, we will hear from Dr. Lauren Ansel Myers. She is Professor of Integrative Biology at the University of Texas at Austin. Following their remarks, we'll have moderated Q&A. And with that, we'll turn things over to Dr. Fisher to begin your presentation. Thank you again, all of you, for joining us today.
Thank you so much for the invitation to join again. It's really a delight to come back and sort of update those that we were in our presentations last time, and as well just give an overview of what's going on and talk about some of the questions that people are having. So Terrence, if you could pop over to my slides. So, you know, we're in a very dynamic situation here in Texas, you know, across the nation. In particular, we'll show the highlights of Texas today and hopefully engage in some really, you know, dynamic and meaningful Q&A at the end. So feel free to ask about any of the information here or your burning questions. So Terrence, let's go on to the next slide, please. So this is information that you may have seen in the media. This is just an update of where we are in terms of the total cumulative number of cases in Texas. I updated this morning, so it's current as of yesterday. We have roughly 270,000 cases reported in Texas and just over 3,000 deaths. The per capita attack rate, so the number of cases that have been diagnosed per 1,000 Texans is 9.3. So that's about 1% of Texans having been diagnosed with COVID-19. Now, of course, remember as we go through these slides and talk about the data today that these are diagnosed cases. So we always will have those who remain undiagnosed, including asymptomatic, including those who have not yet developed symptoms during the course of their illness, and then those that aren't tested for whatever reason. Next slide. So just to give you some perspective, where Texas is in respect to other states. So this is the changing per capita diagnosis of COVID-19 per state. So there's a lot of spaghetti noodle lines on this slide, but I want to draw your attention to that sort of orange demarcated line kind of coming through the middle of that fog and then curving upward. And this is Texas. So what I think is remarkable about this figure that we developed is that Texas was fairly flat, increasing, of course, because as cases are diagnosed, that per capita number, of course, increases. But then, as you remember, you know, within the recent weeks, as particularly following June 1st, we really saw that bend upward. And this is where that dynamic shift in our epidemic happened. And really, as epidemiologists and scientists and clinicians, our ears really perked up. Let's move to the next slide. And you can see others, we're not alone. Some other states are experiencing this as well, but it's really sort of dramatic in Texas. So this is our epidemic curve. These are the daily reports. And just to give you a snapshot of how the daily counts have changed, again, I updated these numbers, and what you're seeing are the total, and on the left-hand figure in the blue lines, these are the total number of cases reported per day. We've had several record-breaking number days in the past couple of weeks. And we are averaging around 8,000 or 9,000 cases per day as a running average in Texas. And then on the right-hand side, the fatalities. So these are the fatal outcomes of COVID-19, again, only among diagnosed cases. And really the running average is hitting about 82 cases a day, again, with remarkable just record numbers of deaths in the last couple of weeks. And so this gray line here represents the case fatality rate in Texas, which of course is decreasing as we expect. And as we hear anecdotes from some of the clinicians across the country, we learn how to, you know, they're learning how to manage cases. They're learning how to triage. We have, you know, treatments that may help some patients, and they can sort of put patients into different buckets depending on their severity, illness, and their personal profile. So these are things that may be contributing to that decline in case fatality. So next slide. So of course we have seen on the news that we're having really a changing sort of shift in our epidemic here. In particular, what's really hit the news, and really starting with a comment by Governor Abbott, that these young individuals, he's really concerned about them driving the epidemic in Texas. So these surge in cases, who are those people and what is going on? And we have seen a lot of younger individuals being diagnosed with COVID-19. And we know from talking to these individuals, you know, just local anecdotes. I talked to patients infected with COVID-19 as part of our case investigation and contact tracing effort locally. And there's just sort of this real sense of a low perceived risk and a low perceived severity of illness that may contribute to what we're seeing in these numbers. Next slide. So just to show you graphically how this has changed. So if we look at the Texas DSHS dashboard on April 5th, and I actually pulled this snapshot from a story by KLTV, but they were highlighting on April 5th this age demographic of COVID-19 cases. And if you'll click the next button, Terrence, if we compare this to where we are today, so I pulled this off the website today, what you see is this real shift toward the left. Now, and so you see, in particular, it's really that, so that 20-year-old age group is that fourth bar there on the left that has really picked up. Now, I want to be clear that this does not mean that we are seeing fewer cases in those older age groups. It's just that there has been a real surplus of cases in these adolescent and young adult, so particularly under 30-year-olds. So again, we are still seeing cases in the elderly. We don't want to neglect those numbers and the importance of those, but we are seeing extra cases in the younger individuals. And as well, from this figure, I pick up this sort of bump in that 80+ year age group, which I think is important to remember. We haven't forgotten about the older members of our community. Next slide. And again, the younger individuals are not immune to severe disease. They're not immune to fatal outcomes. This is a story that has aired on multiple outlets. And it really highlights this sort of this interesting mentality that's emerged or come to light, these COVID parties. And of course, you know, I grew up in the era of chickenpox, and we did chickenpox parties. This is a completely different bear. This is not the disease to play with in a party. It's not the disease to gamble with and you know, play these games about who's going to get COVID. It's a real serious disease. It's dangerous. There are individuals that die for reasons and comorbidities that we don't understand. And just remember that if you contract it or if you pass it to somebody else, it could be you or it could be that person that really is the one who's going to suffer severe disease and end up in the hospital or even have a fatal outcome. Next slide. These are the messages that we really need to find a way to communicate to our younger individuals. So I wanted to update this information. Again, we're not forgetting about our nursing home and our assisted living centers. So Houston Chronicle reported that half of Texas nursing homes are reporting infections. But what we see in nursing homes and these dormitory style living facilities is that these are clusters. So they have outbreaks and they bloom sort of through a center and then often decrease. Or abate and then it may happen again to other individuals in the facility. Can you hit the button a couple times there? I want to pull up this data. So I split this into Texas nursing homes and Texas assisted living facilities. This is data from the Department of State Health Services websites. And what you will notice is we still have a high proportion of fatalities. So the cases being approximately 1,100. Or sorry, 10,000 in these facilities, and then the deaths still about 1,300. These deaths that are occurring in these facilities still account for 40% of deaths reported in Texas, and this is the same number that I reported to you guys 2 months ago. So this may go up and down as we see these clusters and these outbreaks sort of emerge and abate, but really this is not something that's gone away. Next slide. And I really want to sort of talk about what we can do and what we can't do. So there are a lot of don'ts out there. There's a lot of stay home, don't stay, these messages out there that feel really restrictive. And our leadership can give us restrictions on what to do, but you know, it's really down to individual behaviors in terms of controlling the transmission. So again, we still don't have a vaccine that's out there. We still don't have a treatment that's widespread and applicable to everybody with the disease. So what we really have, this tool that we have is prevention, and that prevention depends on us. So if you click down to the next slide, I want to really highlight, so this comes from the Texas Medical Association. They put together what they think are sort of safe and risky behaviors. So the good news is there are lots of things that we can do out there, including social things, including things outdoors, including sports activities, so really healthy activities that we can do that are fairly low risk. And then the other things that become more risky, so as we increase the number of people in our circle around us, as we sort of venture out into the public and accept the risk of those individuals that we come in contact with whose risk acceptance level may be different than our own, so they may not be isolating or careful or around as hygienic people as we would choose to be. Next slide. And then we still are cautioned to remain away from these large crowded public areas, and in particular public areas with common touch surfaces, and then where it's really difficult to stay 6 feet or more away from each other. And this really boils down to what we know about the transmission and the virus. Our knowledge is growing, but the virus, our understanding of the virus has not changed immensely. And then our understanding of the transmission really remains pretty much the same. And this is that we have this primarily droplet spread that will desiccate or fall to the ground largely at that 6 feet level. And then as you shorten that interval, your risk of that distance, your risk of becoming infected increases. So if you're within a 3 feet distance, you're much more likely to contract those respiratory droplets into your own respiratory lining and then potentially become infected. So these pieces of information have not changed, and they're really what we should think about when we're trying to decide what activities we can engage in and where the policies and guidelines should take us. But again, on an up note, we do have a lot of things we can do, and we've learned a lot through the course of this situation. And so we hope that we can start moving in the right direction and bring these numbers down. And that's it.
Well, thank you, Dr. Fisher. That was terrific. What I'll do is I'll speak for a few minutes and then hand it over to Professor Myers, and then we'll leave lots of time for questions. So I'm going to cede a lot of my time to Dr. Myers so she can get all of her points in, and then Terrence, by 11:40, would that be good to start the questions and answers? That's great. So I'll just make a few remarks. I think one is one of the things we just learned from Florida, which I think is very relevant, is that although their epidemic started primarily in young people, and that was sort of the narrative out there that it was all the young people, now we're starting to see the big acceleration in older populations. And I think that's probably likely to occur with Texas as well. So, one of the narratives out there, oh, it's only younger people who are getting sick and they handle the virus generally well. I think, one, that's not always the case. We still see a lot of severe illness and disease among young people, particularly those with underlying comorbidities. And now in Miami, that's clearly affecting older populations as well across Florida. And I expect that's going to happen in Texas as well. That's point one. Point two, I think the other piece to this that we need to give more attention to is I think this virus is really affecting low-income communities in this big resurgence that we're seeing especially in the metro areas of Texas. So African-American, especially Hispanic, Latinx populations, I think are getting hammered by this epidemic. And I do not have the underlying demographic data to support that. It's something that I've been asking for, looking for, and I'm sure it will come. But I'm just based on reports I'm hearing from colleagues taking care of sick patients in the hospital, and some of the scenes that I'm seeing, I'm thinking that especially the Hispanic Latinx community this time around is getting really hit very hard. Certainly that's the case in South Texas, really seeing some devastation at the border in Reynosa and elsewhere, and also on the Mexico side of the border in Tamaulipas State and elsewhere, where it's really horrible seeing bodies in the streets and people dying in the streets, and that really upsets me quite a bit. So I'm really looking for that now to really get our arms around the extent of the Hispanic Latinx community that's affected by this. And certainly in South Texas and Houston, but I'm guessing San Antonio as well. And maybe, Lauren, we'll talk about this a little bit, or we can have some discussion about that at the Q&A. And then, of course, we have to remember that what we're seeing in Texas right now, as bad as it is not unique. It's happening in Florida, it's happening in Arizona, it's happening in New Mexico, it's happening in Oklahoma, and now it's starting to affect the other Gulf Coast states, including Alabama and Mississippi, and now also it's happening in Georgia as well. So there's this swath across the South that's associated with this huge resurgence, and it's happening at a time after the country is already still wary after what happened in March and April when things hit the Northeast very hard. So what's clear is that nationally, we never got our arms around this epidemic. What we saw in March and April is not unique. This happened in multiple European countries, such as in France and Italy and Spain. It happened in the UK, but then things got better. They figured it out, and they brought it down to the point where their nations could live some kind of normal life. If you go into Paris now, there's people sitting out in the cafes, you know, having a glass of wine or a dessert or, you know, some semblance of normal life. That's not happening in the US. We really have to face a national reckoning that we really let this get out of hand when we didn't have to. And I don't think we really understand the reasons for it, but what I've been speaking about is the fact that we never really had a national plan, a national strategy. And by that I mean, we let the decisions to the states and put the states out in front, let the states make the decision, and the federal government would provide the necessary manufacturing horsepower in terms of ventilators or PPE or FEMA backup support, but fundamentally the strategy was going to be led by each individual states. And I don't have a sense of who led that decision, whether it was the White House or the CDC or some combination of that. But I think that's something we have to look at because it was clearly a failed strategy. The states never had the depth and breadth of epidemiologic knowledge to know how to make good decisions. And I say that with all the states, number one. And number two, I think they needed the cover of the federal government to handle the fact that all of the governors were being buffeted by forces to the fringe left and the fringe right with their own agendas. And they really needed the federal government and CDC to have those directives to give them cover, because they were never able to tell their constituents on the right and the left to say, hey, I hear what you're saying. I understand why you don't want to do X, Y, and Z, but the CDC and the federal government is telling me if we don't do this, lives are going to be lost. Patients are going to have permanent disability, permanent neurologic injury, cognitive injury, vascular injury, heart injury, lung injury, and we can't let that level of devastation happen. And I think, and even to this point, we're still suffering from that kind of lack of federal leadership. So, you know, there's a lot of finger pointing going on right now, and I'm very much placing the fault in the hands of the federal government, not at the states, that they could not provide that directive and leadership. And with all those provocative things, I'm going to hand it over to my great colleague, Professor Lauren Myers, who will follow up from Dr. Fisher, and who's done some really fantastic modeling work, and I'm looking at her models on a regular basis and learning a lot from her. So Lauren, please go ahead.
Thank you very much. I'm going to share my screen. Hi everyone, it's nice to be back with you, and I am going to give a less provocative and a little more sterile set of slides that are just showing our analyses, our recent analyses, mostly focused on Austin, where we have access to sort of unique data, the kinds of data that should really be available everywhere in the United States in a situation like this, but unfortunately are not. So Austin provides a good model system where we can actually support decision making there and show it's possible with access to good data and good collaborations between decision makers, scientists, the healthcare systems, and community leaders. And I'm happy to address some of the other topics that Dr. Hotez brought up earlier, and really appreciate Dr. Fisher setting the stage with the kind of overarching situation and some of the really kind of intuitive, sensible, low-hanging fruits that we can do to protect our own lives, our neighbors' lives, our communities' lives. So turning to Austin, these are some screenshots of a dashboard that we hope to have online later this week that just basically provides situational awareness in Austin. How fast is it spreading today? How fast do we expect it to be spreading tomorrow? What do we project will be the number of COVID hospital patients, number of COVID ICU patients in the coming weeks? So the numbers you see across the top, all of these are estimates that are primarily based on 3 daily numbers that we get from the city that are provided by all system hospitals in the city in a really comprehensive way. One is the number of new COVID-19 hospital admissions. the number of COVID hospital discharges alive, and the number of people who've died from COVID in the hospital. So those three numbers on a daily basis allow us to make pretty reliable estimates of how fast the virus is spreading and to make short-term projections. So these numbers are a few days old. I think they're based on data through July 10th. At that point, we were estimating a reproduction number for the virus in Austin, in the Austin Round Rock MSA, the 5-county region, of 0.88. But if you look at the graph below, this is showing it's really important to pay attention to the gray area around the green line. The green line is the point estimate. The gray area is our 95% credible interval. And although that number is below 1, it could be above 1 or it could be below 1, right? So that that credibility interval goes up to almost 1.5. So what is this telling us? It says that we have probably slowed transmission in Austin over the last few weeks to the point that we may have brought the reproduction number below 1, which is that critical threshold that we need to bring the transmission below in order for the virus to start receding in the community. But we may not quite be there. There's uncertainty in our estimates. So as we look at this graph from left to right, what it's telling us is our estimate for essentially how fast this virus has been spreading through time. And you can see the impacts of both policy and individual behavior through time. So in early March, prior to the March 15th closures of schools in Austin and across most of the country, and the March 24th stay home measure in Austin and elsewhere, we estimate that the reproduction number was probably above 3. It then very radically decreased, probably to a point that was below 1, reaching sort of our slowest moment in mid-April. And then it slowly started ramping up, reaching a recent high in the first or second week of June. And then following more stringent policies, more stringent messaging about wearing face masks, staying home in general, staying home if ill, keeping distance, we've seen, at least in Austin, a promising decline in the reproduction number. The second number at the top, as of July 10th, the probability that the epidemic was growing, what we estimate to be 22%. That's essentially what's the chance that our reproduction number is above 1. On that day, we estimated an infection doubling time in Austin of 44 days and a 14-day change of 12% more infections. So on July 10th, there were 12%, we estimate that there were 12% more new infections in Austin than there had been 2 weeks prior. So that's sort of situational awareness in Austin. We use these kinds of estimates on a daily basis to project short-term hospital and ICU demands. We make projections like what you're seeing here. So the green dots in both these graphs on the left, it's COVID-19 hospitalizations for the Austin Round Rock MSA. On the right, it's COVID ICU patients. The green dots are the reported numbers. The blue, the sort of turquoise trajectory is our median trajectory, and all of those gray, what we call spaghetti trends or spaghetti lines, are showing equally plausible future projections based on our estimates. And what you can see on the left is that given the slowdown in transmission, we're projecting a range of possible futures as far as hospitalizations that are under the estimated local hospital bed capacity of 1,500 beds. However, when we look on the right, we are seeing trends that are actually, are you seeing just a single screen or are you seeing all these screens? Which, I'm sorry, I just wanted to.
Just one screen, I think.
Now are you seeing 2?
Yes.
Okay, I meant to, let me just change this. I'm sorry, I'm having a little bit of a technical difficulty here all of a sudden. Let me try this one more time. Sorry. Okay, I'm going to try to go back to that single screen. Okay, sorry, but when we look at the ICU projections, things look a little bit more concerning. We estimate that in the Austin Round Rock MSA, that we might be able to ramp up surge capacity for ICUs to 331 beds and possibly up to 474 beds, but it would require additional resources beyond what the hospitals have in-house. And so we're looking at a projection where there's a chance that we won't hit that capacity by early August, but there is a chance that we will still hit that capacity by early August. And city leaders are hard at work trying to ensure that we will have adequate capacity in the coming weeks. Turning now to these are not actually projections. This is just raw data from Austin, looking at mortality broken down by age in Austin. So this is 7-day rolling average. And you see this really upsetting increase in mortality as of the last couple of weeks. It's upsetting, but not at all unexpected, given the recent increases in cases, followed by the increases in hospitalizations that we've seen in Austin and we're seeing all across Texas. And you can see the age breakdown as well. The dark blue is the 65 and older. The light green is 50 to 64, and the dark green is 18 to 49. I believe last time I spoke, I mentioned our online mortality forecasts. So we make forecasts for COVID-19 mortality for the US as a whole, all 50 states and about 100 metropolitan areas, including some of the large metropolitan areas in Texas. This tool has been online and has been sort of evolving as far as the technology under the hood over the last couple months. It is one of now, I think, about a dozen different models that feed into the CDC's forecasting ensemble. So if you go to the CDC's website, or if you go to the 538 publication, which also sort of monitors the projections, you'll see our model in addition to a number of other models projecting the number of COVID deaths around the country 3-4 weeks out. Some models project out further. I just want to highlight our projections for Texas as of today or yesterday. We are projecting that deaths across Texas are going to continue to increase in the coming weeks. And this is, really what we expect following the alarming surges in hospitalizations. We're projecting that August 1st, there may be around 250 new COVID deaths, but there's a lot of uncertainty. We're projecting it could be as low as 86 or as high as over 1,000. I'm going to share a couple slides that are just providing some recent analysis we conducted upon request from state and local policymakers. So this is a slide of a graph that was requested from the governor's COVID task force. This was shortly before the state provided more strict face mask policies and messaging. And the question posed to us was whether we could quantify the potential impacts of encouraging and regulating stricter behavior, people wearing face masks, keeping their distance, et cetera, in terms of how many hospitalizations might such changes save or prevent. And so this was one set of projections we made. The green was the current trend that we projected as of July 1st when we made these projections. The orange assumed a 16% reduction in transmission across the state. That's about halfway between where we were on July 1st and where we got to in the middle of the stay home measure. So kind of reducing transmission halfway between our lowest point of transmission and the current point of transmission as of July 1st. And we projected, with a lot of uncertainty, of course, that if we were to take measures to slow transmission across the state by about 16%, things such as wearing face masks, maintaining physical distance, staying home if symptomatic, then we would expect that to prevent somewhere between 20,000 and 130,000 new COVID-19 hospitalizations between July 1st and August 17th. The other recent graph I want to share was based on a request from Mayor Adler of Austin. The question he asked us was if the city were to enact stricter measures, something akin to a stay-home measure or other things to encourage people to stay home, keep distance, wear face masks, et cetera, how would that impact the feasibility of opening schools in Austin in the fall? And this one graph that I'm sharing with you addresses it from one angle. So there's 3 different sets of bars. The leftmost bar corresponds to if we were, we did this graph, we made this graph about a week ago, so today was actually about a week ago, but if we were to open schools on that day, given what we were estimating to be the prevalence of COVID in Austin. The second set of bars is if we were to open schools on their scheduled date of August 18th without a reduction in transmission. So that was assuming that the virus is still spreading at the rate that we estimated in the last week of June, and it continued to spread at that rate for the subsequent 5 weeks up till August 18th. And then the last graph, the last set of bars assumes that the city enacted 35-day long set of restrictions. So something akin to a stay-home order for about 35 days, where we really reduced transmission to the point that we had achieved in mid-April during the stay-home measure. So either through a stay-home order or other measures to slow transmission. And so now what is the y-axis? The y-axis is an estimate for how many students would show up in the first week infected with COVID, given the prevalence that we are estimating in Austin under those particular scenarios. The 3 different color bars correspond to different school sizes. So the larger the school, the more kids you would expect to show up infected if there is virus spreading in the community. And so what this shows is that, and the 3 different school sizes are 100 children in the school, 500 and 1,000. So what this basically shows, if we open schools, given the prevalence that we had estimated in the last week of June, then if you have a school with 500 children in it, you would expect that about 4 children would show up the first week of school infected. If we let the virus spread at the rate that we estimated in June, and that continued to spread at that rate through mid-August, then that same kind of school would expect to have maybe 18 or 19 students show up in the first week infected. And if we do really take steps to curb transmission dramatically, what we will actually expect is that the prevalence will continue to increase a little bit, and then it will subside. And by the time we get to August 18th, it should subside a little bit below the point it was at the start of July. And then the expected number of students coming in that first week infected in a school of 500 would be around 3. So some takeaways from the slides I just shared are that COVID, and I didn't show slides from around Texas, but we've heard this in the news. We've heard this from Dr. Fisher, from Dr. Hotez. COVID-19 is threatening the safety and integrity of Texas's healthcare systems in really alarming ways all across the state. And it may, in particular, soon overwhelm ICU capacity in many of our cities. In Austin, COVID-19 transmission has been slowing since early June. Although we haven't done the analysis for other cities, when you look at the hospital admission trends from other cities around Texas, we see similar evidence of slowing, although I don't have numbers to put on it. However, even with that very sort of optimistic sense of slowing, there is still a reasonable chance that COVID-19 could exceed local ICU capacity as early as a few weeks from now. To avert unmanageable COVID-19 healthcare demands, Texas should do more across the state to slow the spread of the virus and to expand safe ICU capacity. The more we do to curb transmission in the next few weeks, the more feasible opening schools will be, in very sort of limited, with limited sort of precautions. And really importantly, better data and better collaborations at the local, at the state, and as Dr. Hotez said, especially at the federal level, the more we can support real-time situational awareness, accurate forecasting, and sensible decision-making. That's really in the best interest of all of our communities. It's really, of all the things that I feel should need to be different today and need to be different in the very near future is just access to data. It's unbelievable to me that something as simple as, as hospital admissions, hospital discharge, or even total number of COVID hospital patients in beds, we still don't have on a national scale. So I do have 2 other slides because Terrence gave us a preview of some of the questions that had already been submitted. And so I've gone ahead and answered a couple of these with using some of our recent estimates. So one of the questions that was forwarded to me was, at this point, how many actual infections do we think one positive test represents? For example, if we get 10,000 positive tests back in a day, is there an estimate for the actual number of infections? My answer is going to be based on Austin estimates, and because that's where we have data to make these kinds of estimates. But what you're seeing in this graph is time on the x-axis, and the y-axis is what we estimate to be the COVID-19 symptomatic detection rate. So for everyone who has COVID and has symptoms, what's the chance that they get tested and confirmed positive? And so based on this, what you can see is that through time, we are detecting a greater fraction of symptomatic cases. And as of, sort of our most recent estimates, if you want to kind of ballpark how many cases there are in Austin based on the confirmed cases, you would multiply by 2 the number of confirmed cases to get approximately the number of symptomatic cases in Austin. And if you want to account for those sort of asymptomatic silent cases, you would roughly multiply by 3. So that's an answer from Austin to that question. And the last question I prepared an answer to is this: what do we need to know about the population that's currently being hospitalized in Texas? How's treatment going for those people? How long do they stay in hospitalized in ICUs? And are they seeing better results than we saw in March and April? And Dr. Fisher spoke a little bit to kind of life-saving, changes in sort of therapies and practices in hospitals that have been life-saving. What we're seeing specifically in Austin is the following. So this is sort of the answer to who's ending up in hospitals in Austin. These are 7-day rolling average hospital admissions broken down by age group. You can see has been a shift through time in terms of what the demographics of who's ending up in hospitals. There was a period of time, particularly in early June, where we saw a surge of younger people coming into hospitals. That's that 18 to 49 dark green curve on top. Most recently, though, we see that the trend has sort of shifted back, where our most recent admissions the most are in the 65 and older age group, followed by the 18 to 49, followed by the 50 to 64. And the speakers spoke to the fact that even when we get this early surge in transmission, maybe in 20, 30-year-olds, they are just simply links and chains of transmission that ultimately get to our more vulnerable populations. And we're seeing that here in Austin today. In addition, a few other numbers to share as we look through time at the hospitalization data in Austin. For a typical person age 65 who ends up in the hospital with COVID, the proportion of that group requiring ICU care has dropped from 52% in mid-April to 39% in mid-June. Survival in the ICU for 65-year-olds has simultaneously increased from an estimated 81% to 84%. For the typical person age 35 who ends up in the hospital with COVID, the proportion that end up requiring ICU care has dropped from 35% in mid-April to 26% in mid-June. And survival in that group, it has increased very slightly, but it sort of stayed right around 97%. So most 35-year-olds survive COVID, even if they end up in the ICU. The length of stay in ICUs for patients who end up in the ICU has stayed pretty stable regardless of age, around 13 days. That's the mean length. And I'll just give you a couple other numbers that I don't have on the slide, but we estimate, actually this is sort of a mid-late June estimate, we estimate that in Austin hospitals that this is for the total duration of hospital stay, that for somebody who goes into the hospital and is discharged alive, who survives, the median number of days in the hospital is 5, and the mean number of hospital days in the hospital is 7.9. That's just sort of across all ages. And for people who go to the hospital and eventually succumb, die from the virus, the median duration of stay is 10 days, and the mean is 13.3 days. And so with that, I just want to acknowledge that the work I shared, the models that have been developed, is been sort of the heroic work night and day of really dozens of people that have been involved in the COVID-19 modeling consortium at UT. And with that, I'm happy to start the discussion.
Great, Lauren. Thank you so much. Fantastic, very informative presentation. We have a gazillion questions. Unfortunately, we don't have a lot of time for questions, and maybe Terrence, next time we do one of these, we give it another half an hour or something along those lines. But a number of the questions have been around opening schools, and I really appreciated Lauren, providing that really helpful information that I haven't really seen presented before, which is, what it means to have opening schools in an area in a time when transmission is going on versus a time when it's not, because it really comes down to the number of infected kids coming into the schools, because the big worry is that the teachers, the cafeteria workers, the bus drivers are all appropriately very concerned about getting COVID-19. And my position on this is you simply cannot open schools where there's an aggressive level of COVID-19 transmission underway. You just cannot assure a safe environment for the faculty, for the people, for the adults working at the hospital, and in some cases, even the students or even the parents where the kids are coming home to in the evening. And so I guess, maybe ask Lauren and Rebecca their thoughts on this, and what is the level we really need to bring it to in the various municipalities and counties of Texas to make teachers and faculty and the staff and the parents feel safe to open up the schools, and what level of risk are we willing to take? And is 35 days enough, or do we really need to lock things down and bring us back to 1 case per million residents per day before we really can safely open schools? We get why we need to open schools. The American Academy of Pediatrics came out with a great document pointing out not only the educational benefits, but the food security issues, the adolescent mental health counseling. The big issue is how do we actually do this? So I'll have Rebecca go first, and then Lauren.
Sure. What a very difficult question to hit me with off the bat, Peter. But this is really important. Parents are worried about their children, and not just young children, but college-age children as well. So I think that Lauren hit on this a moment ago, but it's important to remember that these young individuals are important in the chain of transmission. Our very young individuals come home to families. They may see grandparents. So they are around the community. They may be playing with neighbor friends. So remember that these children, we always think of children as little vectors in disease transmission, and it's no different for COVID-19. They may not display symptoms, but they can be traveling around with the virus. The other thing is that our young adults, our college-age individuals in particular, we see that their age group, now most age groups tend to hang out with each other. So most of their social interactions are with each other, but some of the models that are showing social interactions and mobility data show that this college age group is really key in transmission for the reason that they actually interact mostly with each other, but interact a lot with individuals, including those of retirement age. So who's going to restaurants? Retirees and 20-year-olds. Some very interesting data that I found from London School of Hygiene. So this is important to remember. So in terms of a school opening, if we're talking about, so I'll speak to universities, for example. So universities, we have a lot of students coming in, a lot of resident students, so mobile students moving to somewhere new. So the local epidemiology where they're coming from, as well as where they're going, is really important in their personal decisions to attend in-person school. The other thing is the capacity for that school or the university to do surveillance, monitoring, and if that's syndromic surveillance or testing capacity, to sort of try to keep abreast of the health of their students, as well as find ways to mitigate their spread. An interesting study out of Cornell highlighted that students may be safer on campus versus staying home. And again, this to a university audience, for the sole reason that they're proposing to really monitor disease in their individuals rather than leave them at home where they might not have access to surveillance testing and really monitoring, in particular, asymptomatic individuals that we know are important to spread. So super tough. Super tough discussion. We don't want to pause the education, particularly our young folks that are so impressionable and vulnerable and really are learning from us through this process. Important to not to let that lag. So those are my thoughts.
Thank you, Lauren.
Agree. This is the $1 trillion question. It's so hard because of the costs and benefits on both sides. But here's a few things I can add. So, number one, the graph that I showed about schools, it's really not about how you open schools safely or whatever. It's really about like the feasibility of opening schools. If a school has a zero tolerance policy, which is what we've seen around the world when schools have opened, as soon as you have a case and a staff member and a student, you have the classroom stay home, you have the grade stay home. At some point, you might actually shut down the school for a couple weeks. You have to worry about siblings. You have to worry about, right? If you have a zero tolerance policy, what those numbers just tell you is that you're going to be closing down your schools within a couple weeks of opening them, right? And so that's not about necessarily how you do it safely or not safely. It's just you're not going to be able to do it if that's how you're going into it. So anyone who's thinking about how to open schools safely in the fall just needs to go in eyes wide open. And then, if you really want to do it in a way where you're not going to have to shut down in a few weeks, you've got to do it at a point where there's just not much virus in the community, or you're somehow very strictly screening the people coming into your schools. The second thing I'll add is I have been having conversations with school leaders and decision makers. And one thing that I have kind of advised is, depending on the city, but in a city like Austin, and I know in Houston, other cities, where the city has come up with different stages, different alert levels, I think it's very good for kind of the school to really understand what those mean as far as community transmission, how much there is, what kinds of precautions are being recommended to slow transmission, and maybe to even align their plans according to them. So for example, if we're in a stay-home order, of course, you just can't have schools. If you're in orange, where we really are trying to take the utmost steps without actually staying home to slow transmission, what might that mean for a school? It might mean you figure out who are your absolutely essential people you need on campus, those kids with the most needs, the learning needs, the other social emotional needs. You get them on campus, you figure out innovative strategic ways to get them and the faculty who are willing to be on campus. And that's it. And then as things can get more relaxed, as we have lower prevalence in our community, you very slowly and safely think about how you want to bring others onto campus. And the other thing I'll just mention is, as we're learning more and more about how this virus is spreading, the potential for aerosolized transmission, not just droplet transmission, it's becoming clear that moving groups outside, keeping even more than 6 foot distance and wearing face masks, keeping windows open, all these things are steps that we can take to further reduce the risk of spread if and when we bring kids and staff together in classrooms.
Great. Well, thank you so much. It's unfortunate we didn't get more time for questions, but I think we, hit upon a lot of important topics. Terrence tells me that TAMEST is collecting all the questions and that we can send them to you after the session. And I know people are busy and don't have a lot of time to answer a lot of questions, but maybe a few of the questions so we can post it on the website. So I'm sorry that we did run out of time. Terrence, I'll leave it to you to make closing comments.
Thanks so much, Peter, and thank you to our 3 speakers today. We have just a couple minutes left, and I wanted to call on the 3 of you to briefly perhaps offer a closing thought as we're looking ahead to the next couple of months, and particularly anything that you would advise that individuals can do to help better protect themselves. And then when we have about a minute left, I'll just do some housekeeping to close this out at the end of the session. So Peter, perhaps we can start with you and then hear from Dr. Fisher and Dr. Myers in closing.
Sure, I'll just make the comment that I think that today's session is a good reminder of why we have something called the Academy of Medicine, Engineering, and Science of Texas, TAMEST, that's providing very relevant information to elected leaders in the state of Texas. This is one of the reasons why we were set up, and to be a conduit for sharing of scientific information and best practices. And so I think, this is exactly what we should be doing here at TAMEST, and very appreciative of Terrence for you in setting it up and for TAMEST for organizing this. Lauren?
We're switching the order. No, it's okay. I think I really liked the slide that Dr. Fisher shared earlier that showed all the things, the different levels of safety, the different levels of risk. Really, to the policymakers, whatever you can do to encourage behavior to slow transmission, including incentivizing employers to give people paid time off if they have even the hint of a symptom or anyone in their household does, especially if they have high-risk conditions. So I think from a policy perspective, doing what we can do to slow transmission, protect our vulnerable populations. One thing I just want to go back to, sorry for the extra minute, but this was mentioned, I can't remember by which of the other speakers, but we are seeing in Austin, in addition to that alarming spike in deaths, which we sort of expected, we're also just in the last week seeing a resurgence of cases in long-term care facilities and nursing homes again. So we really need to be protecting our vulnerable populations. And then from an individual perspective, wearing your mask, keeping your distance, staying home just by choice if you don't have to go out, but especially if you or anyone in your household thinks you've been exposed or even has the mildest symptoms. Thank you.
Fantastic. Thank you so much, Lauren. Rebecca.
Sure. Just to leave you guys with a thought about how important personal behaviors are in stopping this pandemic. We know that, we know what to do. There are really no new things that we're want to put out there, but what is new and what we need to look for is messaging. How do we reach people? How do we convey the urgency to individuals that do not so far have uptake of that urgency, and it's not reflected in their behavior? So I want to bring it back again to the young individuals, adolescents, young adults, the under 30s. What is the messaging that will work in these populations that are not seeing themselves and their friends get severely sick, but are transmitters in our community and are important? So we need better messaging, and we need, this is sociologists and psychologists and cultural anthropologists and other scientists that really can help in this regard. And so this is a time really to come together as a community and have this sort of collective sense of accountability and responsibility, and really push behavior change from a level of, from a place of knowledge and understanding. So that's what I like to see. Thank you so much. It's been really fun again.
Thank you to all of you and to everyone that attended today. As we mentioned at the beginning, we will have video of the session up on our website tomorrow, and you'll get an email tomorrow with a video of the session, as well as links to the slide presentations. We are trying to collect all the questions from today. It looks like we had close to 30 questions, and I know we didn't have time to get to all of them, but we'll call on our speakers to perhaps address some of those in the coming days, and we can post the answers on our website. Really appreciate the hundreds of you that joined us today, and in a couple of weeks, we're gonna have another session focusing on health disparities. Dr. Hotez was speaking earlier in his remarks about the disparate impacts that this pandemic is having on underserved communities, particularly here in Texas. Our moderator for that session will be our TAMEST board president, Dr. Amelie G. Ramirez from UT Health San Antonio. And our two confirmed speakers are Dr. Georges Benjamin, Executive Director of the American Public Health Association, and Dr. Quyanta Moore from Rice University. We have an additional speaker that we'll be announcing soon. After the session concludes today, you'll get a link, hopefully, that will take you to a survey if you can give us some feedback. And all of you that were here today will get an invitation to attend our next session. Want to again thank our speakers for sharing the science with us today, and all of you for taking the time to join us. That will conclude our session. Please stay safe and take care. Thank you.